Good morning. Chris Ohl, Wake Forest Baptist Health, Infectious Diseases. So I think two weeks maybe, it'll be exactly 1 year since case zero, which is what we say in the world of epidemiology for the very first case of an epidemic or a pandemic happened. That was Washington State, introduced from China. Soon after, we had some introductions of COVID from Europe, probably mostly Italy, over on the other side of the country. And so that was, it's been a long year. And I know I'm not the only one who feels that way. But just for every day, mark it off on your calendar, one more day closer to this all being in the ending stages. So we're over halfway through it. So keep that in mind as time goes on. So where do we stand with COVID in the country right now? So the big problem places still are Southern California and Western Arizona, and Oklahoma is trying to knock California off as the top case rate place in the country, but so far California is still winning, so to speak. Around here, South Carolina has got the most cases. Georgia's increasing some. Here in North Carolina, actually, both our case rate and the number of cases and the number of hospitalizations is starting to decline. It could decline faster, and I would be happier, but nevertheless, it's starting to come down some. And that includes here in the Triad area, Forsyth County now, our case rates are back down into the 50s for 3 days in a row. That's 50 per 100,000 people, which is the best way to measure numbers of cases. And the counties around us, which have been higher, are also starting to decline, but are still higher than here in Forsyth County. With that, our number of hospitalizations has started to decline some. Again, I'd be happier if they were going down faster, but our COVID hospitalizations look like they're down now for about the past 7 to 8 days. So it is actually a real trend. So, most people realize if you follow the COVID dashboard, hospitalizations follow cases by about 7 to 10 days. And then deaths follow hospitalizations by about another 7 to 10 days because it takes a while to march through. So hopefully our death rates will start coming down too a little bit. So what does this all mean? It means that I think we're through the post-holidays hill, or some call it a surge. I think the surge is a little overused, so I've changed to hill for a while, and that's good news. But what people got to realize, that doesn't mean that this is the beginning of the end yet. So people are going to still have to keep doing what they've been doing, and we need to do, and that's social distancing, masking, and avoiding bubble fusions, which is getting together with friends and neighbors and family that don't live with you. And if we keep doing that, numbers will continue to come down, and that's all good news. We're going to talk a little bit more about masking in a little bit, but first I want to talk a little bit about variants. I get a lot of questions about variants, and I think there's a lot of anxiety out there about variants right now. So let's go ahead and figure out, and I'm going to try to walk you through what a variant really is. So anytime that a virus is circulating in large numbers, and really any virus, as time goes on, there's small little changes in the RNA, which is the blueprint that makes the virus. And when you have small changes in the blueprint, you get small changes in the virus appearance. So it's kind of like if you look at a blueprint for a house. So if you think of the messenger RNA like being a house blueprint, and the house being the virus, that if you change the blueprint a little bit for the downstairs bathroom, that might mean the fixture in the bathroom will change from being white to being purple, for instance. Doesn't make a hill of beans of difference probably to anyone, but that's what that did. But if you change the blueprint for the front door, it's going to change really a big deal for your house. And it's the same thing with viruses. So mutations occur, and they will continue to occur as viruses circulate and move around. But it's where those mutations are that really make the difference for the character of the virus. So when we're talking about these variants, what we're interested in, and I'm going to try to show some pictures if everyone wants to, or draw some pictures, so if everyone wants to pan their cameras. So on the surface of the virus, there's a protein, and we call this the spike protein, and we've talked about this before. And the spike protein sits on top of the virus. This is the protein that binds to a receptor in our airways, in our lungs, and to some extent in our back of our throat and in our nose. And when it binds, it's this part right here of the spike protein that is responsible for the binding, and that's called the pocket. So if you have a mutation which changes this part over here of the spike protein, it doesn't really affect how the virus infects you or how it works. Or if you have a mutation down here, it doesn't. But if you have a mutation up here in this zone in the pocket, it changes the way that the virus binds to those receptors in our body. So if that mutation makes the pocket bind less well, infectivity goes down because it wobbles off the receptor. But if it changes that pocket a little bit so that it binds tighter to the receptor, it could potentially increase infectivity in how well the virus transmits from one person to another. So the virus, that variant that we've been watching the most so far has been in the UK, and that's B11.7 is the name of it. So you might see that written. I don't know if you can see the red ink that well. People are telling me no. Anyway, so that's the one that's in the UK and Ireland, and the one that where the information that we have from how it's being transmitted suggests it's more transmittable. And the mutation in that virus, there's a couple of points up here in the pocket, so it makes biologic plausibility that that virus could be more transmittable. So B117 is what we call that one. Some people call it the UK virus, but UK people don't like that. So we'll call it B117. So and then there's another variant that's in South Africa that has a mutation deletion in that same area. And that one might potentially be more transmissible. And there's a lot more other variants that people are finding that we're looking for. There's one from California, there's a couple more in the US. This is just how viruses evolve. And so now everyone's looking about it and talking about it. It's not surprising. We kind of expected this as time goes on. We expect this with any viral outbreak, and it happens with other cold and flu viruses that go around every year. So it's not a new thing, and it's not sinister. People call it a mutant. I like to think of like the creature from the Black Lagoon as being a mutant. These I just call variants. They're a little different. So the thing is that what we're really interested in is if these variants change the way that prior immunity might protect us from the virus. So when you think about that, so one of the main ways that our body fights viruses is by producing antibodies. Antibodies are in our blood and our serum and in all of our tissues, and they are produced against foreign things that the body recognizes as not being part of us. So when we get infected by COVID, we make antibodies, and a lot of these antibodies are to this spike protein right here. When we get vaccinated, our bodies make antibodies to this spike protein. And these antibodies are all over. They all bind to different areas in the spike protein. So the concern is if you get a change in this area here, the antibody that might be directed to that area may not attach as well. And so that's the concern. But you have to remember that our antibodies from vaccine and our infection are directed all over that spike protein. So one or two small mutations, there's still hundreds of different antibodies that are out there that are going to neutralize the virus. So it's not like one mutation is going to make the vaccine not work anymore. Okay, I'm going to sit back down again if you want to repan your cameras. Give everyone a little heads up. So if you have only one mutation, it doesn't mean that all of a sudden all of the activity of the vaccine is just going to go away. It means it's going to diminish it a little bit. And if you have another mutation, maybe a little bit more. There is so much room in the messenger RNA vaccines that we have out now because they're 95% effective. If we lose a few percentages of effectiveness, it's not going to make a hill of beans of difference. And so that's why you see all this debate in the media about this. And just to show you how odd this can be and confusing, is I read one media report last night talking about two studies that show that the new variants will not be as effectively neutralized by vaccine. And then I went to a different media source and it said, reassuring data that two studies show that the vaccine will still cover the COVID virus. And so I looked up the two studies. It's the same studies that they were both quoting, and they were both taking different attitudes. So my personal opinion is that the new variants are going to be largely covered by prior immunity and vaccine. That's my interpretation of the studies right now. Some other things to keep in mind is that the vaccines that we have right now, there's a little messenger RNA conscript in a lipid envelope, in a fat envelope basically. And that's what enters the cells and makes the proteins that we get immune to when we get vaccinated. It's really easy to change that little messenger RNA conscript. And we do that with vaccines. We do it the flu every year, for instance. We change it to reflect what's going on. So we're monitoring the mutations. We're monitoring these variants. Right now, the companies that are making the vaccines are doing the early experiments that are getting ready to change that messenger RNA in the vaccine if they need to. And so we're already kind of jumping on it a little bit. So as time goes on, we'll tweak the vaccine to reflect what's circulating. This is what we do with viruses and vaccines against viruses all the time. So anyway, that's a little bit about the variants. The B117 variant likely will take over as the predominant virus here in the United States by the end of March, the CDC thinks. That's mathematical modeling. And it just means that's going to be the color of the virus going around at that time. How is that going to reflect the number of cases? Well, it could make things a little bit more transmissible, but we're not talking huge numbers of transmissibility. Probably about 1.5 times the transmissibility of the virus that's going around now. So that means that if you're within 6 feet of a person without a mask for a 15-minute period of time, you might have a 10 to 15% chance of getting it with the current virus going around. If it's the variant, that might be 15 to 20%. So it goes up a little bit. So you wear the mask, obviously, and it's going to go down a lot. if you avoid the bubble fusions, then you don't have any concerns. So all those things that we do to prevent transmission now are going to work against the new variant. Some places in Europe have advised changing masks instead of using the cloth masks to moving to surgical masks. Germany, for instance, and I think Switzerland's going to follow. They're saying to do that in public transportation or other areas where you're in close quarters, and that's just to provide a little bit more protection in those areas. We haven't put out that advice here in the United States now, but we'll keep an eye on that and see. We've said before that if you're in an area that's not well ventilated, that's small, and there's virus transmission, obviously it's going to be a higher likelihood you'll get it than if you're in a big cavernous area or if you're outside or if it's well ventilated. So if you wanted to get COVID, go to a small bar and where the air doesn't move and people are talking or yelling loudly. That's the way to get COVID. And those, if you had to go into a situation like that, yeah, you could get a better mask, I guess. But personally, I'm sticking right now with my cloth masks, and I'm not wearing our hospital grade masks unless I'm seeing patients, and that's a different story. So that's a little bit about variants and a little bit about masking, and hopefully that helps people understand a little bit about what these are and how small changes in viruses occur and how that can change the infectivity. By the way, it's possible that you could have a mutation that decreases the transmission, right, of the virus, but those viruses don't do well in the competition between all of the different variants of viruses. So they kind of fall off and go away. So let's talk a little bit about vaccine. We got a lot of questions to go through on vaccine here, but before I do that, just a little bit of an overview. So right now still we have 2 vaccines out there. They're both messenger RNA vaccines, which is a little bit of messenger RNA in a capsule of fat, nanoparticles of fat. You're not going to see them. And that gets injected, and then your cells make the protein that makes the antibodies. Both of these vaccines still look to be around 95% efficacy, and they start kicking in about 12 days after your first shot, and every day after that 12 days, your immunity gets better and better and better. And then when you get the second shot, you get a boost that brings it up to about 95%. One shot itself is going to give you somewhere between 55 and maybe 85% protection. And then the second shot boosts that up to 95. So the 2 shots is important in the long run. And so far, our guidance here in the United States is to be given 2 shots. Unlike some areas in Europe where they decided right now we're only going to give 1 shot, go with a little less protection in more people. Here in the US, we're still saying 2 shots. It could change, but that's what we're doing right now. So are there new vaccines in development? Yes, they are. And in the next two to 2.5 months, you'll see you'll see a vaccine, AstraZeneca's vaccine, go up for the FDA's emergency use authorization. And then Johnson & Johnson has a vaccine that looks like will be later a bit in the spring. And Novartis has got one that's kind of on the launching pad. And that one might be out towards March. And so we'll have some other vaccines that we can use. We need all the help we can get. So it's, you kind of want, a lot of different players in your back pocket when you're talking vaccine, because it increases supply and it increases the number of vaccines that we can use. So there's some help on the horizon. The 2 current vaccines, Moderna's and Pfizer's out there, are still increasing their production, and so the numbers are going up and going up slowly. And the federal government thinks that there's enough production right now to still ensure that everyone who got a first dose will get a second dose pretty close on time. So that's encouraging. Vaccine rollout, how are we doing? We're getting better. I wish we could get more vaccine into more people faster. I think everybody does. And the number of doses going out is improving. Here in the Triad area, both of our major healthcare systems now are vaccinating patients over the age of 65, and the numbers that we can vaccinate are limited by the amount of supply that we get from the state. And there's kind of two ways of adjusting to that supply. One way is to make a lot of appointments and cancel those if you don't get enough vaccine. Another way is to not give as many appointments and then open them up when the vaccines come. So either way, it creates frustration, and I really understand that. And that getting appointments is hard right now if you're over 65. I'm just saying hang in there, and it'll get better, and it'll get better weekly. So I know in our health system we'll be tripling the number of vaccines we give patients in the next 10 days. So, and I know the other health system in the area is going to be doing the same thing. County-wise, the public health department has been giving vaccines. Their numbers have been somewhere between 500 and 600 a day, and that number is going to go up starting next week again as they move into a new facility. They'll be doing it at the fairground, and they got some help from the National Guard to do that, and some more people. And as the vaccine supply gets better for them from the state, the number of vaccines that are being provided in that situation will also go up. The other thing that people may be hearing about in the future in our area are periodic mass vaccination events. And that's where different health systems or the state or the county, different businesses, different entities get together and put on an event that are designed to vaccinate large numbers of people. People have to understand that the logistics for giving vaccine is not easy. As I said last week, people are used to going into their doctor's office and getting a flu shot, and they get one nurse, they get their flu shot, and they're out the door, and it takes about 5 minutes. Giving a COVID vaccine takes roughly 9 people for every vaccine that you give to people in line. And so it's a little, right now we really can't do it in doctors' offices because of the cold chain and the requirement for all the registration and the monitoring and the people. So that's why you're seeing people come together to give vaccines in places where you can set up all of the people and the space for doing the monitoring in a socially distanced way. And that's why it's not done in doctors' offices, and probably won't be for a while yet. So as time goes on, more and more places are available as these vaccination sites, and so it will get better as time goes on. I think I'll go ahead and move to some questions here. The first one comes from Richard Craver at the Journal, and he asked a couple good ones. And this is questions I hear all the time, and that is, can people choose which vaccine to receive, either Pfizer's or Moderna's? Well, both of these are messenger RNA vaccines. And we get these vaccines in our clinics or in our health systems or at the county, basically by what the state has to give. So sometimes we get Moderna vaccine, sometimes we get Pfizer vaccine. And a vaccination site doesn't have a choice. You basically get what's available. and then we give those. And so it's going to be really hard for an individual person to be able to choose which vaccine they get. And you know what? It doesn't make really a hill of beans of difference because the messenger RNA construct's the same, and the side effect profiles are the same. Both of them need 2 shots, one at 21 days, Pfizer's, one at 28 days, Moderna's, and that's just because it's how it was studied. They're both 95% efficacy, so they're almost essentially the same vaccine. We do say that if you've got Pfizer's vaccine for your first shot, you should get Pfizer's vaccine for your second shot. And if you get Moderna's vaccine for your first shot, you get Moderna's vaccine for your second shot. And that's because the way the studies were done, and we can say with a lot of confidence that that works really well. We really haven't done a study with vaccine switching between the two, so we can say we don't really know so well. But really, it's kind of like if you're used to buying Toyotas every 10 years as your new car, you stick with the one car, your Toyota, because you know it, you know how it works for you. But if you had to switch to a Honda or something else, it doesn't really make much difference in the long run. So I think it's the same way. The ACIP, which is the Vaccine Advisory Committee for the CDC, says that if you got Pfizer's vaccine as your first and Moderna's as your second, or vice versa, don't worry about it. You're likely going to be fine, and you don't have to get a second shot of the other one again. So we're pretty sure about that. Another question that was brought up is how can people who lack transportation and cannot use public transportation get to a vaccine site? Well, there's 2 angles of that, because some places use drive-up as their vaccine. So you drive in your car, you register from your car, you wait in line in your car, you get your shot in your car, you get monitored in your car. I think most sites, though, that are doing that have an area for walk-ins. So the county health department here in Forsyth County, actually, site is going to be walk-in. You wait in the car, the waiting room's in the car, but you actually walk in and get your shot in this big, large, cavernous building. And then once your monitoring is done, you can go. So you don't have to have a car. You can go and wait in the waiting area instead. There is now a service that the state has partnered out with public transportation. This was just announced yesterday, actually, that free transportation can be offered to a vaccination site. And so if you go to the state's website on COVID vaccination, you can get the details on that. And it has to do with contacting the transportation authority in your county. And hopefully today the counties will be up to speed on that. So if you don't have transportation and you want to get to a vaccination site, then there can be transportation provided for you to do that. The county site here in Forsyth County, being at the fairgrounds, is also on major bus routes. And it's centrally located, and it's close to the areas of town that have had historically marginalized populations that have had trouble with access to health care. So I think the site's well chosen for them. Most of the vaccine clinics now are on appointments only and don't have walk-ins. And that's so they know how much vaccine to thaw up for the day from the -80 freezers. Because once that vaccine is thawed, you got to use it. And so we don't like to over-thaw a vaccine because it could lead to wastage, and we don't want that to happen. So for the major, for the health systems in the area, you can go through the MyChart or MyWake Health, depending on which health system you go to. Or here at Wake Forest Baptist Health, you can call 336-70-COVID to schedule vaccine appointments as they become available. If they're not available, keep at it, because vaccine appointments continue to open up as vaccine supply opens up. And the county has access through their webpage, and they're also still on an appointment system. So that's the way to get in. A few other questions that we got from some of our viewers. Lena asked, can you please explain all these different variants, specifically the South African and Brazil variant? And I think we did that, so I'm not going to go over it again. If you need a refresher course in vaccine and protein immunology, there are places out there on the internet where you can learn more. But both the South African and the Brazil variant have these modest changes in that spike protein. And will the Pfizer or Moderna vaccine cover them? Yes, at this time it looks like they do. There may be small tweaks in the vaccine coming out down the road, but right now I'm pretty confident they cover. Candace asks, were there any recommendations or thoughts on vaccine safety during pregnancy or breastfeeding? So, so both of these vaccines that we have out now are not live vaccines, and actually the 3 new ones coming out aren't live either. But they're not. So it's the live vaccines that we don't give in pregnancy. And so technically these should be safe. And as time goes on, we're getting more and more experience with vaccinating pregnant women. And pregnant women who get vaccinated are entered into a registry. And so we can get safety data on that. And so far so good. No major problems. The American College of Obstetrics and Gynecology recommends that pregnant women discuss with their obstetrician the potential of vaccination. Their official stance is that the benefits of vaccination for pregnant women outweigh the risks. And they suggest that pregnant women get vaccinated. But it's a decision for every woman to make individually. There is a very small increase in risk if you're pregnant and get COVID. So that would be a reason to get vaccinated. And we haven't seen any safety problems in pregnant women getting vaccinated yet. So I think it's okay. Breastfeeding, I really am pretty confident that if you're breastfeeding, that vaccination is a good thing to do. And not only for you, but also for your baby. Because when you get vaccinated and you're a pregnant and you're a lactating mom, your antibodies, those little blue antibodies that neutralize virus, actually get in your baby, and the baby's going to pick some of that up as it nurses. And it means you're going to be giving a little bit of immunity to your baby. If you're getting vaccinated and you're pregnant, you make a lot of antibodies. These all cross the placenta and get into the baby's blood too. And so your baby is born immune to COVID and will stay that way for at least 3 to 6 months. So it's another reason to get vaccinated when pregnant. Jessica asks, when do you think kids will be able to be vaccinated? Well, if you ask the 6-year-old, she'll say, never. I don't like shots, but we would like all of our children to get vaccinated. It makes school and their social activities safer, and the population as a whole. So even though COVID doesn't seem to be affecting kids, particularly those under 12, as much as it does adults, and kids do better with it than adults, it would still be nice if they're vaccinated. So right now there's studies ongoing for 12-year-olds and above. I don't think the under 12 studies have started yet. And so it might not be until late summer maybe, when kids will be able to be vaccinated. We'll have to see how things go. I've been asked if there's any clinical trials in the area for children in our area. Right now, right here, just in and around Guilford and Forsyth, no, there are not. But you can track with clinicaltrials.gov, which is the federal clinical trial site, and put in their search engine children and COVID vaccine, and you can see what might be available across the country. Marcia wants to know, why are first responders not being vaccinated into group 3 in our state? So right now, we're still in group 1 and in group 2 for those over 65. At one point, in the first part of the month, first responders were actually in group 2C, and now have been moved to group 3. And the reason why they're in group 3 now is because we simplified and streamlined our grouping for priority in North Carolina, because it frankly was just getting too complicated. So rather than have groups and subgroups now, it's just 1, 2, 3, 4. Group 1 is frontline healthcare workers, nursing home workers, and nursing home residents. Group 2 is those over the age of 65. And then group 3 are people who work in critical areas that are important for community and society functioning. So teachers, first responders, policemen, law enforcement, so on and so forth. Group 4 is kind of the people with underlying health conditions. And then at the end, group 5, it's everybody. So that's the priority system we're going through with the state right now. It might change as time goes on. As you've seen over the last 3 weeks, it's already changed 3 times, so it could change again. Brianna wants to know, is the vaccine safe for adults who have had a terrible case of Guillain-Barre? So Guillain-Barre is a nervous disease that happens where your body makes antibodies against your own nerves. Usually this follows certain infections, and way back in 1976 there was a signal that maybe the flu vaccine that was made that year might have led to more Guillain-Barre. That was 1976. To tell you the truth, we're still debating whether that really was the case. And so, but because of that, people are always a little bit worried about it. But we've really not had any Guillain-Barre associated with vaccines since 1976. And so the ACIP has looked at the data for both Moderna and Pfizer's vaccine and said that there is no suggestion at all that these vaccines will lead to Guillain-Barre. So if you've had Guillain-Barre in the past, you should still get vaccinated. So I'll say that again. If you've had Guillain-Barre in the past, you should still get vaccinated. Karen asks, are patients with a history of anaphylaxis to foods or medications able to take the vaccines? Yes, the risk of anaphylaxis from getting the COVID vaccine is roughly 11.5 per 1 million people vaccinated. So it's not very common. If you like those odds, I suggest you buy a lottery ticket. The people who have more of the risk are people who've had anaphylaxis, particularly to injectable products or other vaccines in the past. So if you have a food allergy with anaphylaxis or an anaphylaxis to a non-injectable medicine, you can tell your doctor and tell your vaccination site, but it is not a contraindication to the vaccine. You can still get vaccinated. Kim gets into the nuances of new vaccines and specifically wants to know about Johnson & Johnson's vaccine, efficacy data from study and release dates. So if you're interested in Johnson & Johnson's vaccine, the release date is still a little bit up in the air. I looked at how far along they are in recruiting, and I think they'll probably be done with the study maybe in the next 3 or 4 weeks. And then they have to analyze the data, put the data together, get it to the FDA. So I'm guessing March timeframe maybe, maybe late February, early March, somewhere in there. So Johnson & Johnson's vaccine is actually an adenovirus vaccine, which they take an adenovirus that can't replicate in a human. They put that messenger RNA construct in it for the COVID spike protein. That gets injected in you, and then that adenovirus makes the protein. It looks safe. The safety data is good so far based on their phase 1 and 2 trials. Efficacy looks good based on just antibody production, but we haven't seen the phase 3 trials yet, data to know how well it works in the population as a whole, so to know that percentage rate. So we'll have to wait until the study code is broken and they release that information. Same thing for Novavax's vaccine and AstraZeneca's vaccine. AstraZeneca's vaccine's data has been published, but there's a little bit of sorting out of their efficacy data yet to know how, based on different dosing strategies, which one will be better and which one provides the best efficacy. So it's anywhere between 68% and 90%, and that's being sorted out now. So far, all the vaccines we've talked about likely will still be 2 doses. Johnson & Johnson's they are studying 1 dose, but I'm guessing that'll still be 2 doses needed. And then lastly, Novavax is making a little bit of a different vaccine. It's a protein nanoparticle that's got an adjuvant in it to increase its immunogenicity. That one might be done recruiting and out a little bit earlier, maybe towards the end of February, early March. So that's what's going on now. And the question is are there advantages or disadvantages to these yet? It's a little too early for me to know. I'd like to see the data and analyze the data myself before I start telling people which one might be best. So, Brianna wants to know, why does the second dose of the Pfizer vaccine tend to cause more expected reactions than the first dose? And what can we do to minimize those symptoms? Well, the clinical trial did say that more people who get the second dose have soreness at the vaccine site and fever after the vaccine. Usually that fever is the night of vaccination or maybe the next day. Usually lasts shorter than 24 hours and goes away on its own. The soreness can last a couple, 3 days. It is more common after the second vaccine, and the reason why is your body was primed to make antibodies during your first vaccination. And so when you get the second vaccination, your body reacts a lot more quickly. You've been primed, like priming a pump. So when you get the second one, your immunologic response is greater. So the way to think about it is this means the vaccine's working, and it's working actually a lot harder the second time around than it did the first time. What can you do to lessen the soreness or the possibility of fever is ibuprofen or acetaminophen. The fancy words for that are Motrin or Tylenol. And it really does work for both. And for people who got vaccinated on Monday, I would say Monday night before you go to bed, take a dose at that time. And it reduces the odds that you'll get a fever that evening while you're trying to sleep. And if you got some soreness, ibuprofen or Tylenol works for that too. When I got my vaccine, I thought ibuprofen worked a little better than the Tylenol, but that is not an endorsement of either product, just to keep me out of trouble. Jimmy asks, You said on one of your sessions last year that you thought we would have all this pandemic on us, behind us by July. Do you still feel this way? Yeah, that was my 4th of July briefing last summer, because I said, I think by 4th of July in 2021, we might be able to say we have independence from COVID. Yeah, I still think by July 4th of this year, things are going to be feeling a lot better for us. Will we be totally out of it? Probably not. Will we still be masking? Probably. But you know what? I think we're not going to be worrying about it every day and letting it consume our lives like we are now. Or at least a lot of people feel that their lives are being consumed by it. So I think this summer is going to be a lot better. I think we'll still be masking and still doing some form of distancing probably into the fall. And which will go away first. I think the masks will probably be the last thing we toss. And that just comes down to the fact that we talked about, it's like having the virus on a mud run. The thicker the mud is, the harder the virus has to get through it and to get transmitted. And the thickness of the mud is the number of people we have vaccinated or are immune from natural infection. The depth of the mud is the mask and social distancing. So if you make the mud deeper by wearing the mask and doing social distancing, you'll slow virus transmission. If you make the mud thicker by getting vaccinated or having natural infection, you make the mud thicker and slow it. If you do both, you slow transmission 5 to 10 times more than just by doing either alone. So that's the strategy for us to get out of this. So kind of a long briefing this morning. Apologize about all the science we had to go through. Is there any questions from the room? I think there are. Sure.
Dr. Ohl, President Biden has called for 100 million vaccines in the first 100 days of his presidency. Estimates are that this will have to quadruple the rate at which we are currently vaccinating people. What needs to be done here locally to achieve that goal?
Yeah, it's a good question. So President Biden has said he wants 100 million doses in the next 100 days. And is that achievable both nationally and locally? Tony Fauci said last night, yes, he thinks that's achievable. I agree with them, actually. I think it is achievable. Yeah, we're going to have to really increase our rates of vaccination. I think that what needs to happen, first of all, we need more vaccine. And so the manufacturers have to be stepping up. So both Moderna and Pfizer have made recent adjustments in their manufacturing processes to increase the supply that comes out the end of the line. I'm blocking on the word. Conveyor belt, I guess is the word I'm looking for. So they're going to be stepping up production, and we're going to start seeing that real quick. And then the second thing that is going to happen is we're going to have streamlining of the distribution system through the states into different areas. And that is actually already improving behind the scenes. And I think the federal government's going to be making some changes to that. That's going to help. Third thing is that we need better data systems for recording vaccines that are given, and that's being worked on too. Was that the third thing? Fourth thing? I forget what number I'm on. And then we're going to have a lot more people putting needles in arms. And having mass vaccination sites is one very efficient way to do that. Another way to do that is to step up local health systems' abilities to do it for their own patients. Another way to do it is to step up the capacity for getting vaccines into marginalized and populations that have troubles with access to health care, and getting over the vaccine hesitancy. And that's a big deal. People need to be comfortable that the vaccine is safe and effective. I've said it a million times here that it is, but people need to know that.
Will we likely see, excuse me to interrupt, vaccinations 24 hours a day?
Well, we see vaccines 24 hours a day. Probably not 24 hours a day. There may be some areas where it would make sense, like in certain workplaces or hospitals where people work 24 hours a day, but we have to also look out for the resiliency of the people who are providing the vaccines. And running them into the ground is in the long run not productive. And so we have to make sure. I think that the way to do it, rather than doing 24-hour vaccines, is just to increase efficiency in the number that we can give in the hours that make sense to people. The last thing I want to say is that if we can get some vaccines out there in the production lines that we've talked about, that are coming out, that are being studied right now, that don't have to have a minus 80 or a minus 50 degree freezer, that's going to help a lot, because then we can ship those out to doctors' offices and increase the number of places that people can get it. So that's a good question, and those are the things that I think will need to happen to get 100 million in 100 days. Question here.
Yeah, I'm doing a story about people who've had COVID and the vaccine. If people have had COVID, should they get the vaccine, and how long should they wait after they get COVID?
Okay. So the question is if you've had COVID, should you still get the vaccine? And it's a good question, because when you get COVID, most people get immune. And at least they get immune for, the official guidance is 90 days, but it's probably actually longer. We have some studies saying that that we think it's up to 8 months. And so should you still get the vaccine? Well, if you do get the vaccine after having COVID, it will boost your immunity. And because that vaccine thinks that COVID, when you got it, was actually like the first vaccine. It doesn't know the difference. So it boosts your natural immunity. So that, in that sense, it's a good idea to do it. How long should you wait? The ACIP says, well, you can really get it anytime after you've recovered from COVID. But they say some people might want to consider putting it off for 90 days or so, because they don't need it as much as their 85-year-old neighbor who hasn't been vaccinated or had COVID. So in other words, being a citizen and letting somebody else kind of cut in front of you in the line because you've had COVID and you're probably immune. The other thing that we're going to have to watch is that particularly very frail elderly people who've had COVID, when they get the vaccine, might have more serious local reactions and fevers. We don't know that 100% for sure yet, but we're looking at that. So in summary, if you've had COVID before and it's been within 90 days, be a good citizen and let somebody else get in line. If it's after 90 days, go for it. But in either event, you should get vaccinated. If you're a frail, elderly person, talk with your doctor before getting it.
And I was going to ask that, is there such thing as having like too many antibodies, so it could kind of be dangerous? And like you said, with those frail people, they kind of get more severe symptoms if they've had COVID and get the vaccine.
Yeah. So is there a problem with with getting more antibodies for COVID? No, generally that's a good thing. The more different antibodies you have, the more likely you're going to cover that spike protein all up. So that's a good thing. The thing is that if there's a reaction that might cause some fever and increased heart rate, for instance, when you get a fever, your heart rate goes up, and that always goes together. It's like your body thinks it's going for a run, so it raises its heart rate. So if you're an elderly person with bad heart disease and your heart rate goes up, and you have a lot of other medical problems, that may not be good. So people who have a lot of underlying medical problems, who've had COVID before, and particularly if they're over the age of 80, should talk with their doctor. That would be my recommendations right now. There's no official guidance that says that, but I think that just makes prudent sense. So over 80, a lot of other medical problems, and you've had COVID, so those three things together. Question?
Yeah, I just kind of wanted to get a status check. You were talking about the healthcare workers who are doing these mass vaccination sites, not wanting to overrun them. Obviously, healthcare workers with hospitalization rates, even if they're going down, you said yourself, they're going down a little slower than
Yeah.
Can you give us a status check on how they're holding up with the patient count?
So how are healthcare workers doing? Admirably. I'm proud of all of our healthcare workers, throughout the state. Yeah, well, people are pulling extra shifts, they're working harder. But resiliency is important, so we've been trying to look out for that. I can almost guarantee you there is not one healthcare worker in the state who isn't ready for this to be over. It's stressful to just keep going. I mean, they've been at it for a year in some places. Here in the Triad, not quite so long. So, but yeah, they're stepping up admirably, and we're trying to do what we can to help with resiliency and people. Having the number of COVID hospitalizations go down is helpful. Yeah. But people have to also understand, for healthcare systems, while we're taking care of all these COVID patients and while we're really busy, we're also trying to run vaccinations. And so we're trying to do two things at once. And for particularly the employee health people, they're really having to step up. And so hats off to them across the whole state.
Any hesitancy for taking the vaccine from healthcare workers?
Has there been hesitancy for taking the vaccine for healthcare workers? Some hesitancy. But overall, it's a lot better than what would have been indicated last fall. You remember if last fall, before the FDA approval and before we had the great efficacy and safety data, and before there was concerns from some people that vaccine was being rushed, which it wasn't, there was a lot more hesitancy. But I think people are really coming around now. We still would like to see people in historically marginalized populations get the information that they need to get to make great decisions on getting the vaccine, which they should. And we're working on that. So. Any other questions? Great. We'll go ahead and wrap it up. See you here next week.